Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 456 of our pharmacotherapy series, which majors in pediatric malignancies. The next case reads, SGC is an 18-year-old man with a 2 to 3 month history of left shoulder pain. A tumor is found on radiograph, and biopsy confirms a high-grade conventional osteosarcoma of the left proximal humerus. No apparent metastases are found with CT and bone scans. Renal function, left ventricular ejection fraction, and hearing tests are all within normal limits. SGC begins neoadjuvant chemotherapy consisting of high-dose methotrexate alternating with cisplatin and doxorubicin. 6 cycles of this chemotherapy, cisplatin, doxorubicin twice and high-dose methotrexate 4 times, will be given before his surgery, after which he will receive 2 more cycles of cisplatin, doxorubicin, each followed by 2 cycles of methotrexate, then 2 more cycles of doxorubicin, each followed by 2 cycles of methotrexate. So my questions to you read: what is the goal of chemotherapy? What is the role of pre-surgical, that is neoadjuvant, chemotherapy in SGC? Because SGC's osteosarcoma is in his proximal humerus, the surgeon can remove the primary tumor using one of the various operations described in the literature. Limb salvages typically work well in the upper extremities, with fewer complications than when they are used for lower extremities. Because patients with osteosarcoma usually die from metastases, the goal of the chemotherapy is to eradicate micrometastases, which are present more than 80% of the time, as discussed in the previous section. Neoadjuvant chemotherapy of osteosarcoma was developed to treat micrometastases while waiting for limb salvage surgeries to be arranged, performed, and healed. Neoadjuvant therapy may improve limb-sparing surgery by shrinking the tumor. It also allows histologic grading of the response to initial chemotherapy at surgery, a prognostic factor for risk of relapse. However, no convincing evidence to date indicates that disease-free survival is better for patients who receive neoadjuvant chemotherapy relative to those who receive their chemotherapy as adjuvant therapy. In SGC, a titanium bone implant was placed where the diseased humerus was removed. The ease of doing this surgery may have been enhanced by neoadjuvant chemotherapy-induced shrinkage of the tumor. At surgery, SGC's tumor shows excellent histologic response, shown by 99% necrosis of the tumor sample. At diagnosis, his lactate dehydrogenase was 220 units per liter. So my next question to you reads: How do these prognostic factors affect the choice of therapy in osteosarcoma? Conventional staging systems do not correlate well with prognosis for most bone cancers. Clinically apparent metastases are a location that does not allow complete surgical removal of the primary tumor or associated with a poor prognosis. Newer surgical techniques and treatments have improved the prognosis, with 20% to 30% of metastatic patients cured using neoadjuvant chemotherapy and surgery. Other potential prognostic factors have been identified. However, few of these factors have been used to stratify patients to different treatment regimens. SGC has a minimally elevated lactate dehydrogenase consistent with a relatively small tumor mass, although this is not used to stratify for treatment. The percentage necrosis of the tumor at surgery correlates with risk of recurrence. In current studies, patients with greater than 90% tumor necrosis after 6 cycles of neoadjuvant chemotherapy are considered good risk and are treated with standard chemotherapy such as SGC is receiving. Patients whose tumors have less necrosis at surgery are considered to be standard risk, and they have a higher risk of treatment failure. No treatment modifications to date have demonstrated better outcomes for these patients than the good risk protocol described above. After reconstructive surgery using a titanium implant, SGC restarts his chemotherapy. During his 4th cycle of chemotherapy, after high-dose methotrexate is given, SGC's peak methotrexate concentration is 1,300 micromolar and the 72-hour concentration is 0.22 micromolar. The normal value is less than 0.1 micromolar at 72 hours. Recorded urine-specific gravities are less than 1.010, urine pH is between 7 and 8, and urine output is greater than 2 to 3 milliliters per kilogram per hour, which, according to guidelines, suggest a reduced risk of methotrexate-induced nephrotoxicity. His creatinine has increased from 0.9 to 1.1 milligrams per deciliter, creatinine clearance of 106 milliliters per minute per 1.73 meters squared. However, he does not have any signs or symptoms of methotrexate toxicity in spite of his delayed clearance. Leucovorin rescue, dosed at 15 mg IV every 6 hours beginning at hour 24, is continued. So my next question to you reads: what potential problems could be causing his retention of methotrexate? Accumulations of protein-containing fluids, called third spaces, such as pleural effusion and ascites, or gastrointestinal obstruction, may retain methotrexate and slow the terminal excretion. Slow excretion of methotrexate allows more proliferating cells to be exposed to methotrexate during the S phase of the cell cycle, increasing the cytotoxicity and resulting in more mucositis and myelosuppression. Many drugs interact with methotrexate, which can also slow its excretion. Cisplatin reportedly reduces the excretion of methotrexate because of nephrotoxicity, especially at cumulative cisplatin doses greater than 300 mg per meter squared. SGC has received 4 doses of 120 mg per meter squared. That is a 480 mg per meter squared total dose of cisplatin, which may have contributed to the reduced methotrexate excretion. He has not received concomitant nephrotoxins, such as aminoglycosides or amphotericin B weak organic acids, such as salicylates, non-steroidal anti-inflammatory drugs, penicillins, or trimethoprim sulfamethoxazole, TMPSMX, can compete with methotrexate for renal tubular secretion via the organic anion transport system. Proton pump inhibitors are thought to more directly inhibit transporter proteins and have been reported to delay methotrexate excretion. Although SGC's serum creatinine appears to be the same that it was at diagnosis, 1.1 mg per deciliter, serum creatinine is not always a good indicator of renal function, so it is possible that SGC has had some renal damage that is not apparent from his serum creatinine concentrations. A measured creatinine clearance was 176 ml per minute per 1.73 meters squared at diagnosis, and a repeat at this point is 106 ml per minute per 1.73 meters squared. Even measured creatinine clearance may not always be accurate when compared with CR ethylene diamine tetraacetic acid measurement of glomerular filtration rate. Although the reduced renal clearance may be contributing, it is not clear why SGC is retaining methotrexate. Future courses of methotrexate need close monitoring. My next question to you reads: how long should leucovorin be administered to SGC? Leucovorin is a tetrahydrofolate that bypasses methotrexate's block of dihydrofolate reductase and reduces the toxicities of high-dose methotrexate. It, therefore, can be used as a form of methotrexate rescue. Cytotoxic effects of methotrexate depend on concentration and duration of exposure. Many high-dose methotrexate protocols continue leucovorin rescue until serum methotrexate concentrations are 0.1 micromolar, which would be expected to occur approximately 72 hours after a 12 grams per meter squared dose infused over 4 hours. Because SGC has delayed methotrexate clearance with persistence of methotrexate levels still above 0.1 micromolar at 72 hours, prevention of gastrointestinal and bone marrow cytotoxicity may require continuation of leucovorin rescue until methotrexate concentrations are less than 0.05 micromolar. For SGC, methotrexate concentrations did not fall below 0.1 micromolar until 108 hours after his dose. Thus, leucovorin was continued 24 hours past that time to ensure presence until methotrexate fell below 0.05 micromolar. Other considerations may also be important in patients receiving leucovorin rescue. Because of the competitive nature of leucovorin rescue, higher leucovorin doses may be needed for patients with excessively high methotrexate concentrations. Petros and Evans describe that the methotrexate concentrations, those above the blue shaded area, place patients at high risk for methotrexate toxicity if given the usual low rescue doses of leucovorin. Methotrexate doses, that is 12 grams per meter squared infused over 4 hours, are designed to produce peak methotrexate concentrations in the blood of 1000 μm, followed by less than 10 micromolar at 24 hours, 1 micromolar at 48 hours, and 0.1 micromolar at 72 hours. Higher concentrations may result in greater toxicity and additional leucovorin doses may be necessary. If SGC's methotrexate concentrations had remained more than 1 micromolar 48 hours after the beginning of the infusion, current COG recommendations are to increase the leucovorin dose to 15 mg per meter squared every 3 hours until methotrexate concentrations fall below 0.5 micromolar. If concentrations exceed 5 micromolar 48 hours or more after the methotrexate dose, higher doses of leucovorin are recommended. that is 150 mg per meter squared every 3 hours. Oral leucovorin administration should not be used when the patient has emesis or requires large oral doses, that is above 50 mg, which are often poorly absorbed. If a patient on high-dose methotrexate experiences renal failure and has elevated concentrations of methotrexate, glucarpidase, carboxypeptidase G2, may be used in addition to the leucovorin. Glucarpidase hydrolyzes methotrexate into inactive compounds and is very effective at quickly lowering methotrexate concentrations. However, it generally needs to be administered within the first 96 hours after the methotrexate dose. In spite of rapid reduction of methotrexate concentrations, it is not clear the extent to which it lowers morbidity or mortality from the high levels and delayed clearance. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 457.